Yeah, live.
Hi, good evening, everybody. I welcome you all to the 21st episode of ISM SICS webinar series. Before we begin this episode, I would like to call upon Dr. Prakash Marathe, sir, Chairman of the Maharashtra chapter of ISM SICS, to pay homage to the victims of the Air India crash.
Good evening, everyone. I think there is a little bit change in the sequence today. Before the start of real program, there was one tragedy in India and across the world. The whole world was shocked because of the tragedy of Air India crash. That is Ahmedabad to London flight, and all those customers and who all were in bad shape. And that particular tragedy involved the medical college, that is BJ Medical College, Ahmedabad. So many doctors, they lost their lives and most of them are injured. So at the start, we will pay homage to all those departed souls and all those who are injured, we pray for them to get well soon. So I request all of us to just keep silence for a minute. Om Shanti. Thank you. Thank you so much.
Om Shanti.
Over to you, Dr. Amir.
Thank you, sir. I now call upon Dr. Anil Shah, sir, our president, to introduce today's webinar.
Thank you, Amir. Good evening, my dear colleagues. I, Dr. Anil Shah, President for Maharashtra chapter, welcome all of you to this wonderful series webinar that is A to Z of manual small cataract surgery. Today is episode 21 and the title for today's episode is Mastering Cortex Aspiration in SICS Step-by-Step Technique. The aim of SICS webinar is to popularize SICS by series of webinars to enrich our knowledge, to emphasize how SICS is safe, cost-effective, with minimum learning curve, to emphasize its usefulness for community basis, to involve expert surgeons to share their knowledge and experience, and to make SICS interesting and a popular technique. Here are few important remarks. In surgery, knowing what not to touch is as important as knowing what to remove. The art of cortex aspiration is not removing but in preserving what must remain untouched. Small details in cortex aspiration leads to big difference in surgical outcome. We don't just remove cortex, we restore vision and renew lives. Here are a few images showing various types of methods for removing cortex aspiration. For this webinar, we have chairperson Dr. Prakash Marathe and Dr. Jignesh Taswala, and the speakers for this webinar who are expert in their field with the best of their knowledge and experience, Dr. Shekhar Paransbe, Dr. Prashant Shukla, Dr. S.S. Patti, Dr. Shivagami N. The discussion for this webinar, who will argue, debate and dialogue, we have Dr. Saurabh Luthra, Dr. Kishore Pahuja, Dr. Sanjay Tekavade. And the moderators who will preside over the webinar, making the discussion enjoyable and effective, we have Dr. Ameya Kulkarni and Dr. Pankaj Shah. I am really very much thankful to all the colleagues, speakers, discussant, moderators for sparing their valuable time and making this webinar a grand success. Thank you. Thank you very much. I'll hand over to Ameya.
Thank you, sir, for the wonderful introduction. Now I call upon the office bearers of ISM SICS to give us their thoughts on today's webinar. So I'll call upon our Vice Chairman, Dr. Parikshit Gokte, sir, for his thoughts. Dr. Gokte?
Give me a minute. He's in the car, I think. Yeah.
No. Again, once more, congratulations to Dr. Marathe, Anil Shah, Dr. Amir, Dr. Pankaj, and everyone for holding this on a very, very regular basis and having something new, not just for newcomers, but for even veterans like me who have been doing small incision cataract surgery for many years. So every time I listen to the webinar organized by Anil Shah sir, Marathe sir, and the team, there is always something new that is learned. So yeah, just looking forward to hearing it from you. And of course, thanks to all our friends out of Maharashtra who have taken time and joined. Thank you.
Thank you, sir, for those kind words. I would now like to call upon Dr. Prakash Marathe, sir, our Chairman, Maharashtra Chapter, for his thoughts.
Good evening, everyone. Respected office bearers of ISMS-ICS, central as well as local Maharashtra body. Then speakers for today's webinar, chairpersons, discussants, and the most important, all the participants. I think this is the wonderful series organized by our chairman, Dr. Anil Shah. This is over 2 years now. When we were undergraduates and postgraduates, there was no chapter of SICS, even in books of ophthalmology. But whenever we were thinking about SICS, probably one must think that maybe 1 or 2 webinars. But this is going for years now, and every month we have been holding this particular webinar. So how much is there in SICS to learn that I think he has thought of? And that particular syllabus is like university syllabus, starting from incision and anesthesia and whatnot. Every aspect of SICS he has covered. And in these webinars, I am seeing many more presenters across the country, across the globe, and they are sharing their knowledge. And most of the seniors as well as newcomers, juniors, they are being benefited by this knowledge of SICS. On this platform, recently, I am seeing most of the phaco surgeons also. The people, when they are invited, they say that I don't do SICS. Why are you calling me? Why are you inviting me? But we tell them that this is not only SICS, but even phaco surgeon is supposed to know exactly what happens if there is a complication, how to convert. And that particular thing, if you are not learned, probably you are trapped. If you are pure phaco surgeon. So one must know everything. Most of the medical colleges in the past, recently till 5 to 10 years ago, they were not teaching SICS. Big medical colleges, I know. But nowadays, they have included in their training sessions the SICS session and those patients they are training now. I think this webinar definitely has helped Maharashtra members as well as the members across the country and even internationally. These webinars are available online also. And this is sort of syllabus and book of webinar. And I must congratulate Dr. Anil and our team for taking these efforts. I welcome again all of you for this webinar. Hopefully, it will be the wonderful webinar to add. Okay. I request Amir to take forward.
Thank you, sir, for those words. I now call upon our very own Dr. Anand Pangarkar, sir, for his thoughts. He's our Chair Scientific Committee for the Maharashtra Chapter. Dr. Pangarkar?
I'm trying to tap the speaking, but it's not coming through.
Sir, we can hear you, sir. Your video is gone, but we can hear you clearly. Now you are muted yourself, sir.
I think we should come back to Dr. Pangarkar later. So I'll hand over to Dr. Pankaj to continue the webinar to introduce our esteemed speakers and our chairpersons. Thank you.
Thank you, Ame. Good evening, all of you. My screen is visible?
Yes, visible.
Yes, it is, sir.
Thank you, sir. So it's wonderful evening and we have galaxy of speakers, chairperson and discussions today with such an interesting topic. To begin with, the chairpersons for today, we have Dr. Prakash Marathe, sir, our own. He's a chairman, Maharashtra Chapter ISMICS, past president of MOS, POS and IMA Pune. He has been a faculty at installation of Australia and New Zealand chapter of ISMICS and has been organizing various conferences and has various awards to his name, and very active ISMICS proponent and very strong proponent for all SICS surgeries. Next chairperson we have Dr. Anil Shah sir. He is from Nandurbar and President ISMICS Maharashtra chapter. And we all know that he has many awards from MOS also for his snare, large foldable IOL for MSCS, modified intracystic implants, and best research private practitioner award to his name. We come to our third chairperson today is Dr. Jignesh Taswala from Pune. He is a past president of MOS, past president of POS, and he's a managing committee member of AIS also. We have esteemed speakers, Dr. Shekhar Paranjpe sir. He is from Sangli and he has done his MBBS from Miraj and PG from Pune. He is a trustee of Mrs. Tarabai Paranjpe iBank and a very avid enthusiastic bicycle rider plus avid sport enthusiastic and badminton player. He always believes that riding bicycle on gym is not an option. Better ride a bicycle always wherever you go. Then we have a next speaker is Dr. Prashant Shukla. He is from has done his MBBS from Aligarh and PG from University of Meerut. He has a surgical retina and training institute and training done. He is chief consultant at Sai Jyoti Eye Care Aligarh and managing cataract and medical retina cases. And Dr. S.S. Bhatti sir, he is a practicing ophthalmologist and a clinical experience of 25 years of teaching and clinical. He has done his MBBS and MS from Mumbai. He has diverse interests other than ophthalmology in computers and photography. He is a firm believer and adage that knowledge expands only when it is shared, and also that do not reject the old teachings only because they are old, but evaluate them on merit, and that is why he still does manual SICS in significant number of cases. One more esteemed speaker today, Dr. Shivagami. She is a pediatric ophthalmologist at Arvinda Hospital, Pondicherry. She has completed her MBBS from Chennai and DO from Arvinda Hospital, and she is a recipient of gold medal, Rema Mahan gold medal, and various publications to her name. So I hand over to Amey again.
Thank you, sir, for the short introduction. I'll be introducing the discussants. Initially, we have Dr. Saurabh Luthra, who's a DO-DNB cataract and refractive surgeon. He practices in Bilaspur. He's the director of Luthra Vision Care and Research Center. He's the president of Bilaspur Divisional Ophthalmic Society. He's also a member of executive body of the Chhattisgarh State Ophthalmic Society. He has many firsts to his name where he adopts technology the fastest amongst everybody around. So welcome, Dr. Saurabh Luthra. Next, we have our very own Dr. Kishore Pahuja, sir. I have the easiest task of introducing somebody who doesn't need any introduction. He's a cataract refractive surgeon in Pimpri Chinchwad. He's done his fellowship in Boston. He's also done a short fellowship with Professor Daljit Singh in Amritsar. He's established Natasha Eye Care and he's director of Niramaya Hospital. Welcome, Dr. Pahuja, sir. We have Dr. Sanjay Tekavade, sir. He's a cataract refractive surgeon. He's done his graduation and post-graduation from BJMC Pune. He's done his senior residency at Taparia Institute of Ophthalmology, Mumbai. He has an observing fellowship at Moorfields Eye Hospital and he practices in Pune for the last 30 years. Welcome, Dr. Sanjay. Now, as the formalities are out of the way, we would like to get on with the academic feast. So I would like to call upon Dr. Shekhar Paranjpe sir as our first speaker today.
I will share my screen now. Give me some time, please. Yeah, almost ready to go. May I start?
Yes, sir. Please start. The floor is yours.
Sir, the PPT is not visible, sir.
This started as a slideshow.
Yeah.
Can you, sir, reshare again now? Just ensure the PPT is open before you share.
Yeah, I'm ready. Am I audible now?
Sir, audible, but the PPT is not visible, sir.
To Pranju, I think you need to first stop sharing, start the PPT, and then share the PPT and not the folder.
Okay.
So don't close the PPT once you've opened it. The PPT should be there, then share.
First we stop
Now it
sharing,
is open.
I've stopped the share. Just ensure the PPT is open, then come back to the Zoom window.
then come back to the share and share the PPT and not the folder in which the PPT is.
Now, shall I share from here?
Yeah, share and please select the entire screen on the first window.
Is this okay?
Perfect.
Yes.
Perfect.
First stop share.
Then you stopped again, sir. It was good. It was good. You could have gone.
Open the PPT.
No. Just share. Just share again.
Yeah,
It was
you
good
were
because
doing it, sir, but then you stopped.
it was visible. You stopped. Just share again, simply, sir.
Do you have it at a backup?
Now is this okay?
Just sir, waiting. Yeah, perfect, sir. Absolutely perfect.
Perfect.
Backup is there.
Perfect.
We are waiting for it to. Now we can see it's perfect.
Okay, na? So shall I start?
Yes, sir.
Yes.
Good evening, everybody. Today's my topic is Cortex Aspiration, a boon of AC maintainer. AC maintainer, or better mention about it is self-retaining AC maintainer, is either 20 gauge or 23 gauge. For SICS, I use 20 gauge, while for phaco surgeries, I use 23 gauge AC maintainer. As of now, I know two AC maintainers. One developed by legendary Dr. Blumenthal, which has got front-facing opening, while second is by Dr. Anil Shah, which has got a blunt tip and two side boards. In our hospital, I follow two rules whenever I am doing SICS surgery. The rule one is main wound, that is SICS or a scleral tunnel wound or phaco wound. It is used only for the nucleus management and IOL implantation. This is a strict rule. While the rest of the maneuvers like capsulorhexis, nucleus rotation, bringing nucleus in AC, IOL positioning are all done through sideboard. The second rule is AC maintainer first to go in and last to come out. And infusion line is never closed, it is always on. AC maintainer is either connected to normal saline, ringer lactate, BSS with infusion set. Bottle height is variable as per the need. This my presentation is basically technique oriented, where AC maintainer is continuously on, and because of AC maintainer, you work under positive intraocular pressure environment. Coming to the cortex aspiration, I can divide cortex into four categories. One is cortex bowl or epinucleus. Second is actual cortex. Third is epithelial cells on the posterior capsule. And fourth is epithelial cells on the posterior surface of the anterior capsule and equator. So we will first discuss about cortical bowl or epinucleus. Cortical bowl cannot be aspirated with 23 gauge aspiration cannula. It needs expulsion through the main wound by creating a positive pressure into the antechamber, either by visco or fluid pressure by anterior chamber maintainer. In anterior chamber maintainer technique, gravity-fed pressure is used to remove the cortical bowl by increasing or decreasing the bottle height. Now we'll come to a video film, short video films. Now there is a big chunk of cortical bowl or epinucleus is there. You just press on the scleral lip of the wound, and with the AC maintainer on, all epicapsular material pops out. You can see here. There will be one more video like this. Same way. You just infuse little saline with your cannula, 26 gauge cannula, and then once all epinucleus is loose, you just press on the scleral lip of the wound, and then the cortex epinucleus pops out. Once the epinucleus is out, actual cortex is to be managed. With AC maintainer on, only side port is used for cortical aspiration. I use 23 gauge single function cannula with silicone tubing attached to it with a 10 ml disposable syringe. This video clip is for phaco surgery, where all cortex will be aspirated with the help of AC maintainer and aspiration cannula. Here you can see the phaco wound where some fluid is also leaking out. As you will realize, this all maneuver is done with only single entry. No repeated entries are required. And usually 5 to 7 ml of aspiration and cortex comes into the syringe. Very rarely you have to do another entry. Now some little more cortex is on the posterior capsule. And here and then this is a subincisional cortex. I think video is stopping in between. Now this is a cortical aspiration for SICS. You can see the SICS wound here. You will realize that this wound is not at all leaking in spite of positive pressure into the anterior chamber because of irrigating fluid. And second thing, you will realize that the pupil is not at all constricting. You are working under very stable anterior chamber. This is sort of a subincisional cortex. You have to just rotate the tip towards it and aspirate it out. Usually this is all can be managed through a single port. Now once main cortex is out, the cortex on the posterior capsule, either you have to vacuum polish it or physically polish it. Now you can see here I am physically polishing it. I'm sure it is properly seen. I'm polishing the posterior capsule with the same cannula, aspiration cannula. Very rarely we use Nightingale syringe polisher or any other instrument like that. You can polish the posterior surface of the anterior capsule also. Almost all cortical cells on the posterior surface are aspirated. You can see the wrinkles that are created on the posterior capsule, but absolutely no concern. The epithelial cells at the equator and notorious sticky cortex. Here what I use is a 50 gauge fiber optic cable with UV light. This is a unique product developed by my friend Dr. Rajiv Raut from Pune. That UV light is a very low intensity light, and it necroses the epithelial cells at the equator, and then they loosen out and they come out very easily. Within seconds, you can manage this. Here I will show you the video film. Now this is a fiber optic cable, and it is connected to a UV light, and it is doing the job of epithelial necrosis. You can say this is very few people actually use it. I believe not more than 10 people all throughout the world must be using it. But it is a wonderful this thing. Now, whatever left cortical cells which are loosened by ultraviolet ray, you can very comfortably remove it. And I am doing the polishing or vacuum aspiration of the posterior cortical cells on the posterior surface of the entry capsule. The use of self-retaining AC maintainer, there are two extreme use. One set of surgeons are there, they say AC maintainer is indispensable, while others say I am happy with my visco. It would be very interesting to make arrangements something like this in PG studies also. A group of few PG students are made to convert from visco to visco-free AC maintainer surgery teaching, while another set of PG students are directly plunge into the AC maintainer type of technique. And that will be, it is very interesting to observe how they progress. So in conclusion, during cortical aspiration, minimal requirement in the cortical aspiration is that there should not be meiosis, iris should not pop out in between, and minimum entry for cortex aspiration into the anterior chamber. If you have seen my 2, 3, 4 videos, then you will realize that there was absolutely no meiosis. Iris, there was absolutely no chance of iris popping out, and there was only single entry cortical aspiration. AC maintainer fulfills this requirement. Secondly, whenever we are observing other surgeon surgery, we always say how much he is doing. Oh, it is too much. This reaction comes when the surgeon is trying for his perfection. So perfection is sometimes enemy of good. But is it really so? Really perfection is enemy of good? If we change the technique, then the enemy should lead us to a perfection of higher level. Thank you very much. Thank you. My presentation is over.
Yeah. Thank you, Dr. Paranspe sir, for those innovative videos. I would like to now invite Dr. Prashant Shukla sir to present his presentation.
Just a second, I'll do share. Is it okay?
It's perfectly visible, sir.
Okay, a very good evening to all my esteemed senior eye surgeons here and my colleagues and all the friends who have joined us in this webinar presentation. Well, today my topic is manual versus automated cortical aspiration in manual small incision cataract surgery, the pros and cons and case analysis. So should I start? There are basically 3 modalities of cortical aspiration which we use in modern day cataract surgery. The first would be the cortical aspiration using Simcoe, which is a manual system. The second would be using a bimanual INA system in manual small incision cataract surgery, which is automated. And third would be the use of a coaxial INA system, which normally we use in phaco surgery. So today I'll be talking about the comparison between basically between Simcoe and a bimanual INA, which we normally use in manual small incision cataract surgeries. So there are certain prerequisites of like having a safe cortical removal. First would be there has to be no loosened tags of anterior capsule, so that we don't inadvertently catch the anterior capsule and have a posterior capsular rupture. And second would be a very good cortical cleaving hydrodissection as shown in the video, so that the cortex gets separated out from the capsule, and a good nucleus rotation, which we normally do in manual small incision cataract surgery, so that it helps to loosen out the cortex as well. Well, no surgical technique is good or bad. Every surgeon has to learn and master all the tools which are available. And I feel using a specific instrument, whether it be Simcoe, which is a manual system, or an automated IA system during small incision cataract surgery, would purely be surgeon's comfort and preference. So in my comparison videos, I shall be using the word relative more often, as I feel the systems are relatively better than the other in terms of functionality and availability to the surgeon. So here comes the comparison. The pros of using a Simcoe cannula would be that Simcoe cannula is a relatively inexpensive tool. It is simple to use, cost effective. It's got a shorter learning curve. Aspiration is more controlled in surgeon's hands, and it is one of the most commonly and widely used instrument in manual small incision cataract surgery. And on the contrary, the automated aspiration system is expensive compared to Simcoe. A phaco machine is needed for automated cortical aspiration. The cost of phaco consumables is high, so it's not a very cost-effective system, and certainly there's a learning curve while using the automated system. So here I'll be demonstrating the comparison video side by side for better understanding. Excuse me. Well, intraoperative meiosis is a frequently encountered situation during manual small incision cataract surgery, especially when we are removing a hard, big nucleus. And then comes the challenge of removing the cortex, because when the pupil comes down, then it's basically a blind procedure to remove the cortex. First, I'll show, and in this case, I feel the use of a Simcoe cannula, which is a manual system in which the vacuum rise is slow and more controlled, it is a relatively safer option than using a bimanual IA. So in this case, first the loosened out cortex epinucleus is just removed using the water jet of the Simcoe cannula. And then from the main port, first I'm going to try and remove this cortex at 6 o'clock. With controlled aspiration, one can see we can remove as much of the cortex, even with a pupil size about 3 to 3.5 millimeters. And there are very less chances of catching the anterior capsular margin because the vacuum is very controlled. On the contrary, this is an uneventful case in which a small pupil, and I have used a bimanual INA system, and here I'm going to demonstrate how safely we can use it. So the parameters in normally I use a vacuum of about 350. In this case, I have reduced the parameters to about 250. This is a Venturi based system which controls the AFR automatically. And now I'm going to show how safely we can remove. The anteriormost leaflets of the cortical matter are just held near the pupillary margin, and a sweeping motion is done so that any chances of damaging the capsular margin is avoided. A slow and controlled way we can also use INA system, but it carries a certain risk of damaging the capsular bag zonular apparatus, because the vacuum rise is fast, and by the time we get to know that we have caught the anterior capsule, the game is already over. This is another case. This is one of the another pros of Simcoe, in which I have demonstrated the use of Simcoe in a compromised rhexis margin. This case was initially posted for a phaco surgery. We can see a small side port here. After decompressing the back, this is a patient of about 65 years who had long-standing diabetes, and the case was intermittent cataract. And after decompressing the bag, after doing a small rhexis, the moment I initiated the larger rhexis, the rhexis went to the periphery and there was a rhexis run out. So I thought it would be a good idea, considering the size of the nucleus and the poorly dilating pupil, I converted it. So with the water jet, superficial cortex is now been removed and the epinucleus is just irrigated out. And now the pupil has come down. So I thought, let's do a viscomydriasis to just isolate the cortical chunk, just like that. So now you will be using a Simcoe cannula from the side port with a very controlled aspiration with my hand, and slowly, without even touching the intercapsular margin, I can just very comfortably and easily remove all this cortical chunk. And because the aspiration is more controlled, there are very less chances of complication and a rhexis run out, even if we catch hold of the intercapsule inadvertently. Here I shall be demonstrating the use of bimanual INA system. It carries a significant risk of capsular extension because the reflex is more of a machine dependent. This is a similar case in which I had a x-axis run out. I am going to remove the cortex from the area of the rhexis run out. Because the flow is fast, the loose ends of the intercapsule, they are just flapping around the aspiration port. So there was small cortical chunk which was left. Just now we'll see, which I could not remove in the first go. So I thought, let's implant the intraocular lens and then I'll remove it. I tried again. After implanting the intraocular lens, I tried to remove that chunk again, but unfortunately I could not do it for the fear of catching the tone edge of the intercapsule, because it was coming again and again to the aspiration port. So I thought, let's just leave it. So I find this is certainly a limitation of using the bimanual INA system in case of a compromised rhexis margin. So now we come to certain cons of the Simcoe cannula, which would be relatively the pros of the bimanual INA system. What I have encountered is there is significant amount of chamber fluctuation when we use the Simcoe cannula through the main port, because it is not a very closed system. We can see in a moment. The superficial cortex and epinucleus is just removed using irrigation. And while using the Simcoe cannula from the main port, we can see the iris is moving a bit. There's a lot of chamber fluctuation. The chamber is not very stable. So I tried using it through the side port. Still, the chamber is better, but still we can encounter certain chamber fluctuations, because in case of a Simcoe cannula, we have to make a slightly bigger side port. So there are certain amount of fluid leak from the side port as well. On the contrary, when we use a bimanual INA system, even in small incision cataract surgery, we can see the wound here. Got a very good valvular incision, and the chamber is very tight, rock solid tight, and there is hardly any chamber fluctuation while we use the bimanual INA. We can use it through a small gauge. It is a more of a closed system. We can switch hands and we can do a very good 360-degree cleanup. There is in this case, it is a relatively better option over Simcoe. And we can even switch hands. We can go 360-degree. Bimanual INA is a better option when it comes to the chamber stability. Even the irrigation handpiece can be used to just retract the iris and find any hidden cortical element below the iris. One more presentation I have got. This is my own experience. Well, not written in any book or anywhere. I feel while using the Simcoe cannula, there is more of a cortical movement around the aspiration hub, aspiration tip. So basically, the design of the Simcoe is like the fluid goes along the side of the aspiration port. So when we use the Simcoe cannula, this is a case in which after the nucleus removal, there was a lot of epinucleus and there was a big fibrotic plaque over the posterior capsule, which I'm not going to touch. And I'll demonstrate what exactly I want to mean. Firstly, the loose epinucleus is just removed using the fluid jet of the Simcoe cannula. This is a 23 gauge Simcoe I'm using here. And there is a small chunk of cortex at 6 o'clock, which I'm going to, which I'll try removing it using the Simcoe. But I'm not going to, I mean, I won't be successful doing it. Probably every time I take the Simcoe at 6 o'clock, the cortical matter would just disappear below the rhexis margin. Just in a second, we'll see. It would disappear in below the rhexis margin, and I won't be able to catch it. Maybe probably the flow is more linear. So I thought, let's implant the lens and then remove it. Again, the same thing was happening. Every time I was going near the cortex, it was disappearing. So I thought, let's change the direction of the fluid away from the cortical matter. So it can only be done while we use the Simcoe from the side port. So I'll be doing the same thing. I'll be taking the Simcoe from the side port and change the direction of the fluid away from the cortical matter. When we have got a big cortex, then it is easy. In a small cortex, this makes some trouble. Now I can remove it so that the fluid is directed away from the cortical matter, and then it is easy to hold. On the contrary, while using a bimanual INA system, the aspiration port is almost at 180 degrees from the irrigation port. There is very less movement of the cortex at the angle of attack where we are aspirating. Only the cortex moves when we just take it near the irrigation handpiece. The flow is from the side of the irrigation handpiece. It's not from the straight area. Now hands are switched. Now it is better seen. The cortex below the rhexis margin is hardly moving. Only it moves when we bring it into the center. And in that way, it is very easy to catch the cortex without any movement. And it is the surgeon ability to remove the cortex. It is a bimanual technique. Again, we can switch hands, so it is relatively better in comparison to the Simcoe cannula. One more video I will be showing. In this case, I feel the followability of the cortical pieces and the epinuclear pieces is relatively less in cases of using a Simcoe in comparison to the bimanual INA system. We'll see in a moment. The loose cortical matter and the epinuclear elements are removed just by irrigation. Probably because of the linear flow of the thing, the pieces are first repelled, and then they come to the tip for aspiration. Also, we have to hunt for the small cortical pieces if they are just roaming around into the anterior chamber. And this is a case of a hard mature cataract. The superficial epinucleus and the cortical elements are just washed out using the irrigation handpiece. And there was a big chunk of epinucleus hiding below the anterocapsular margin. We'll see in a moment. Here, with the cortex, that epinucleus chunk came out, which previously it was not visible. Here it comes. So I thought of breaking it up. The moment I used to break it, all the small pieces would just automatically jump on the aspiration port with the press of the foot switch button. They were just jumping on. Even I was removing the cortex, the pieces were coming to the tip. So in this way, we can see that the followability of pieces is slightly better in terms of INA bimanual than using a Simcoe cannula. It is a closed system, so probably because of that, we have got a better followability of the cortical pieces. There's one more interesting case I have. She was a diabetic patient of 60 years, and after collapsing the nucleus out of the capsular bag, I had a floppy iris, and it was just coming out again and again. So this was a challenging case, so I thought, let's just remove the nucleus first. So I adopted the phaco sandwich technique. I tried to put the iris back, but it was not going. So I adopted the phaco sandwich technique to first remove the nucleus and deal with the further steps afterwards. So after removing the nucleus, a small part of it just broke out of near the angle. So I'll be using the irrigation fluid from the bimanual INA system to just remove all this matter first. Here the bimanual irrigation system comes. Iris was coming out again and again, so I thought let's just leave it for a while and remove whatever the cortical matter as well as the cortex which is sticking on the posterior capsule. Just remove it using the irrigation handpiece first. There was a certain amount of cortex which was left here, so I thought it is an open chamber. Let's not use the bimanual INA for the fear of having a collapsed chamber and to add on further more complications. So I thought let's just implant the intraocular lens first. Whatever cortex was removed from the posterior capsule, after implanting the intraocular lens, I thought the parameters were reduced. The bottle height was increased from 90 to 100. And the parameters again, this is a Venturi machine I'm using. And the parameters were decreased down to about 200 mm of mercury. And safely, the cortical matter was then removed over the intraocular lens. So the intraocular lens worked as a scaffold so that even we have a collapsed chamber, there are very less chances of having a posterior capsule rupture or further complications. There was a good amount of cortex which was then removed comfortably. Then after the iris was reposited back, some amount of, okay, some more cortex is left somewhere here. Yes, there's some more cortex. Again, even there is an open scleral wound. We can see that the chamber is relatively better formed. It's not very shallow, although things are going slowly than normal, but without any difficulty or any problem, I could remove all the cortex 360 degrees. Here I've implanted a 3-piece intraocular lens for better stability. So now the some amount of intracameral carbachol was instilled. The scleral wound was closed using 310 nylon interrupted sutures. And the patient did well. She had against the astigmatism also, and she was very happy. This is how the case looks at the end of the surgery. Well, it's a few tips for all the young surgeons who have joined us. And frequent chamber shallowing using a Simcoe cannula could be avoided by using good amount of viscoelastic every time the AC shallows and then remove the cortex. Well, my mentors have told me, please don't run after small tags. They can be taken care of after IOL implantation, where IOL can work as a scaffold and protect the PC. And while learning bimanual INA system, it would be a good idea to keep continuous irrigation on at all times because all the young surgeons may not have very good foot control. And last but not the least, double check the type of Simcoe which you are using before surgery. I always do, whether it is a direct or a reverse Simcoe. Well, we all use direct Simcoe. Reverse Simcoe we hardly use in our surgeries, but once I had this instance of reverse Simcoe being delivered to me, and the surgery after, I mean, the fluid was coming out from the aspiration port, and every time I used to go near the cortex, it was just moving here and there. So it's always better to check the Simcoe which we use in our surgery before surgery. And thank you so much for your patient hearing. Thank you so much.
Thank you, Dr. Shukla. I must commend you on your quality of videos. Fantastic videos,
Thank
well
you,
edited.
thank you, Dr. Ame. Thank you so much.
Yeah. So now I call upon Dr. Bhatti sir for his presentation.
Okay, I think you all can all see the slides now.
Yes, sir.
Yes.
Uh, I think quite a lot of how to do eye has been covered, but I'll just give a few of my views on it, which are not necessarily in opposition to what you've heard, but are sort of complementary. In some ways, they support them. Sometimes they may slightly differ. Now, when you want to do cortex removal in SICS, there are basically three considerations. Dr. Paranjpe had classified them differently. I'll classify it a little differently. One is removing epinuclear cortex, removing cortex inferior in the inferior part, and in removing the subincisional cortex. And we'll consider, we'll look at these three considerations one by one. Now, if you want to remove epinuclear cortex in a small incision cataract surgery, there are two ways. One is to use a blast cannula. A blast cannula is a big bore cannula, maybe 18 or even 16 gauge cannula, which flushes a large amount of fluid into the anterior chamber, and it forces out the epinuclear cortex or the epinuclear bowl. Right now, this basically is harking back to our extracapsular days. That means the technique is where you flush a large amount of water into the anterior chamber, and everything in the anterior chamber that is not firmly attached will come out. That means the epinuclear cortex. The cortical part which is firmly attached will not come out with the blast cannula. The other method is that you could use a Simcoe irrigating aspiration cannula, but which has a large irrigating port. That means, in other words, you don't have a 0.1 or a 0.2. You can actually have a 0.3 mm aspiration port and maybe a 20 gauge irrigation. I've written here Simcoe with a large irrigating port. What I actually should have written was with a large aspirating port. Now here we will see one video. This is the use of a blast cannula. Fluid goes in. Everything that is not firmly attached anywhere comes out. Right? So this would be one way to remove the epinuclear cortex. And you can also remove it with a large Simcoe. And here, when I use a Simcoe, I again use both techniques, the very old-fashioned open chamber techniques as well as the closed chamber techniques. That means I will use my Simcoe both through the main wound as well as through a side port. Now, in this case, the entire nucleus is out there and it's a very soft nucleus. So this shows you that a large bore Simcoe can not only remove the epinucleus, it can sometimes remove even the nucleus. Go in and dissecting out the nucleus, and the bore, it is managing to remove even the well. Now, when you use a side port like this, you have superior subincisional area very well. Always attack your cortex or epi opposite. That makes it very easy. Much of manipulations. Now, please notice that when you shift from the wound to a closed chamber eye from side port, there are two different systems operating. One is what is called a constant volume. Into the eye is constant. That is through the main port. And when you go in through the side port, it's a constant pressure system. So you have to make sure that your bottle height is not too high, because otherwise when you go in through the side port, you can have unusual deepening and raise in pressure of the anterior chamber. Right? So here you can see all the epinucleus has been aspirated, leaving only the cortex behind. Now you could attack the cortex with the same eye cannula, but then you have to be very careful because large bore aspiration ports generally tend to catch the capsule as well. So removing the cortex is better done with a slightly smaller bore aspiration, because that, even if applied to the anterior capsular leaf, doesn't usually aspirate it. And of course, as we've already seen during removal of the epinuclear bowl, that you could remove the cortex also the same way, either through the main scleral tunnel incision, which will be a constant volume system, or you could use a separate side port, either with a Simcoe or with a bimanual system. And subincisional, it's always better to make a side port somewhere else, either temporally, nasally, or inferior. I like to make an inferior side port, so you have a direct direction of attack for subincisional cortex. And another thing to note is, that you don't have to randomly. The technique is you catch the end, pull it to the center, and then you could also, if you wanted, not aspirate in this case, and then diametrically opposite. It makes the subincisional cortex. So the trick here is attack the cortex side ports as required, and catch the anterior capsular leaf of the cortex, strip it to the center, and then increase the suction to aspirate it or strip it right out of the wound. And thank you.
Thank you, Dr. Bhatti sir, for the wonderful presentation. Our next speaker is Dr. N. Sivagami, but I don't think she's there.
Hello, Ame.
Yes, sir.
Sunil will be presenting from his side.
Yes.
Sunil, you present the video.
Vacuum assisted cortex removal. Concerned to manual small incision cataract surgery, the legacy of Simcoe cannula will leave a remarkable footprint in the sands of time, despite the need to flush repeatedly and also retain a constant pull over the plunger of the syringe, which is indeed a physical strain in addition to stress to do a safe surgery. The need for repeated flushing due to inadequate volume of aspiration and the highly variable vacuum relying entirely on manual pull is very fluctuant and completely dependent on the surgeon, which in case of beginners can even cause posterior capsular rent. We all are aware of the syringe with spring action used in femto surgeries to build up the pressure and stabilize the globe, which had also set the stage for safe device, spring action apparatus for fixation of eyeball. Got into action and experimented it. Unfortunately, to our disappointment, the reality while using a thin coiled spring on a 5cc syringe inside the eye's anterior chamber did not meet our expectations. However, with persistence and determination, we tried with a range of springs of varying coil thickness and varying number of coils. Eventually, when inadequate volume was the only concern, we jumped in and started trials with a 10cc syringe. After a lot of analysis, we ended up with an appropriate diameter thin caliber coiled spring with approximately 11 coils, producing just the adequate pressure, and named it VCR, Vacuum Assisted Cortex Removal. The plunger and barrel of a 10cc syringe are first disassembled. The coiled spring is inserted on the plunger and the syringe is assembled. With the spring in a state of compression, the Simcoe cannula is introduced into the anterior chamber and the thumb slowly releases the pressure on the flange of the plunger. The release of spring creates vacuum that allows the cortical material to fill the port, which is then manually stripped off its attachments and hence aspirated. The initial phase has a controlled but dynamic vacuum which gradually decreases during the later phases, leading to slower aspiration. We can manipulate the rate of aspiration by keeping a hold on the flange, limiting the relaxation of the spring. The controlled vacuum produced by VCR avoids any sudden aspiration of ocular tissue as with traditional Simcoe and hence minimizes the risk of posterior capsular rent. Also, any inadvertently caught iris tissue or posterior capsule can readily be flushed out. The gradual and gentle vacuum gives us the liberty to hold the syringe freely in left hand and concentrate on cortical aspiration, making it more advantageous for beginners and trainees. Also, the larger volume of effective aspiration helps complete cortical cleanup in one go without the need to repeatedly flush out the aspirated contents. VCR fulfills all the criteria for an ideal device. Change does not change tradition, it strengthens it. It is an opportunity and not a threat. Likewise, VCR is an economical, effective and novel change to the tradition and a small step forward towards comfort and safety.
What a wonderful innovation there. I'm sure we'll have a lot of discussion over it. But before we go to the discussions, we
I
have
will,
a small
Anuj,
video by Dr. Anil Shah, sir. He would like to present a small video.
I will share my technique of bimanual irrigation aspiration. How to go to the computer means I want to go there. How to go to the main screen in the computer where? How to minimize this?
So there will be one view. You have to escape full screen from that.
Okay, I should close it, no?
Close that view. Escape full screen. Just make it.
Escape.
Otherwise you can just do an Alt tab. You will come to the main screen. Alt tab.
Alt and tab on the keyboard, sir.
Alter and tab. Achha.
Yes.
Yeah. So you'll come to that screen.
Alter and
tab.
Tab button.
Tab.
ALT and tab.
I will exit full screen. No.
Or just escape. Just press the escape button.
How to? Yeah. My video is in the computer. How to go there?
Sir, in your Zoom screen only down, if you scroll, you will get a full frame to mute, start video, participant, raise hand and share. That's where you need to touch the share option. And
share. Share.
So वहाँ से you will be able to share your page of the computer which will come and then maybe play the video from there.
Because you need to on it in your
Yeah, it's coming.
It's coming, sir. You have
at the end of the slide, just click the entire screen rather than slide.
This is a screen, no?
You have to reshare, sir.
Where? I close it, no?
It's not shared now.
No, I want to go to my computer. The video is
No, sir. You share a screen first.
So first of all, go to your the particular folder in which your slideshow is and open the slideshow outside of Zoom. After that, you go to share, and then that will be one of the options that you can share.
Means from here, where should I go?
Minimize the Zoom screen. Minimize the Zoom screen first.
Minimize from where? Here.
Right side, on
Zoom
right side.
application.
See, on the right side, upper side, there is one cross, there is one rectangle, and there is a dash. That dash you can click, so this screen gets minimized. And now you are allowed to open your video. Once that video is open, then you can share. Yeah.
Okay, now.
Yeah, it is coming. It is coming.
Yes, okay.
It is your introductory talk. No, it is a video only.
All
video
good, sir. All sir. Yeah.
I'll
Go to the
direct
top and start.
video. Yes, this is the video.
Okay.
Dear colleagues, I am Dr. Anil Shah from Suryakant Eye Hospital. In this video, I am demonstrating modified bimanual and manual aspiration cannula. The advantages are that it doesn't cause any anti-capsule pull, there is no zonular dialysis, no PC rent. Anterior and posterior polishing is possible with sandblast. Cortex cleanup deep in the fornices is possible. And even after oil implantation, cortex cleaning under the rhexis rim without catching the iris is possible. This is a normal aspiration cannula with the tip facing upward. Now with the needle holder, the tip is made straight. Now the tip is rotated horizontally. The flow of fluid is directed horizontally. Now the same cannula is again given the same curve, original curve. Now here you will notice that the fluid is coming out horizontally. So the aspiration port is directed horizontally. Normally it is vertical aspiration, but it is directed horizontally. Now this horizontal aspiration cannula is passed into the anterior chamber. It is going deep into the capsular rim, crossing the capsular rhexis margin deep into the fornices and removing the cortex easily without catching anterior capsule or iris or even the fornices of the capsule. With this, it is a very safe removal without any tension of catching anterior capsule or even the equator of the capsule. The cortical cleanup is completed. Now with this same cannula, you can go deep into the fornices and polish the anterior capsule or posterior capsule and do a complete. Now this is a case 2 where the pupil is smaller and there is a thick epinucleus plate of cortex. Now in this situation it is very difficult to remove the epinucleus plate, but with this horizontal aspiration port the epinucleus plate is removed easily. You can go blindly deep into the fornices below the capsular rim without catching anterior capsule or iris, and you can remove thick plate of epinucleus easily. So it is very safe method of removing anterior cortex. This is a case 3 where also you will find a small pupil with thick epinucleus plate. These type of epinucleus and cortex are very difficult to remove with the tip facing upward cannula, but with horizontal tip facing cannula it is very easy to remove. See, the epinucleus plate has been taken out from the fornices and removed. It is very simple and safe method, I think. It doesn't cause any damage to posterior capsule or even doesn't cause any pull on the anterior capsule, and you can blindly go below the iris and take out the cortical matter easily. See, in the fornices also the cortical matter is removed blindly without any problem. Now this is a case 4 in which I am going to show you a very small fragments of cortex deep into the fornices can be removed very safely. This is a chunk of epinucleus, which is easily pulled out from the capsular bag. With the irrigation, the chamber is made stable, so there is no fluctuation. I always prefer bimanual irrigation aspiration rather than other methods. Now see here, the small cortical fragments are remained into the fornaces. With the horizontal tip facing cannula, we try to remove this cortical fragment, though it is adherent and not easily coming out. So we'll try to remove from the other side cortical matter. So this is a deep cortical matter in the fornaces which is easily removed. Now here a sticky cortical matter is adherent to anterior and posterior capsule, and this type of cortex are very difficult to remove. But with this horizontal facing cannula, you can easily take out without any pull on the anterior capsule. Now the remaining cortical matter is also removed by passing the horizontal tip facing cannula deep into the fornaces, and the tiny fragments of cortex are easily removed. So there is a total cortical cleanup, and the advantage is that the anterior capsule and posterior capsule are not at risk. Now this is another method, manual cortical aspiration by Dr. Anil Shah's ACM and a horizontal facing aspiration cannula. Those who are doing manual aspiration, my modified ACM is very useful, and this cortex aspiration cannula is also very useful. This cortex aspiration cannula has a tip facing horizontally, same as that of the aspiration cannula. Now this is my modified ACM which is available with the Ankur metal. The advantage is that it has got the two side holes at the tip, and this ACM can be attached to side port for aspiration and irrigation. This is another Simcoe cannula which I have modified, having a tip facing horizontally. Normally we see a tip facing on the front, but I have modified this with the tip facing horizontally so as to easily remove cortex deep into the fornaces without catching anterior capsule. Hope you like this technique. Thank you very much for your kind attention. Thank you very much.
Thank you, sir. Before we begin our discussions, I would like to ask Dr. Pankaj Shah sir to please take over.
Thank you, Amay. Really wonderful videos and presentations. Now let's have some discussions on this. I invite Dr. Sanjay Tekawade sir to give your insights about this presentation. Dr. Sanjay, please. I think he's not there. Dr. Sanjay? You can go ahead with Dr. Saurabh Luthra, sir. So please. Can you share?
So I must congratulate all these speakers about the phenomenal presentation, and everybody had a tip. I also tend to realize after so long that SICS is something where you've experimented so much. Now we cannot experiment in fake. Coming up with the spring cannula, spring syringes, and shaping of the cannulas. So whatever works best in either of the hands, yes. But there are few takeaway points from mine would be, of course, whenever you want to convert as Dr. Prashant guided that on that mature cataract day when he felt that it's going beyond his hand, it is always better to convert. And of course, in the open chamber cases where the tunnel is not that great, or those floppy iris cases, I would still go ahead with my Simcoe only to be on the safer end, because those automated versions would at times give away, and that sudden junk of fluid will obviously make the AC go haywire. So I think the good old Simcoes work better in my hands. I would say that. I mean, at least for the young surgeons who are probably getting into SICS and all those things. And of course, the AC cannula, as Dr. Bhatti also sir said, and Dr. Shekhar sir said, it is a boon to a lot of us. And I think with the help of with the advent of those cannulas, we have been able to do a lot of other maneuvers also. You start with the SICS and probably it somewhere helps you do a glued IOL later in the phase of your life. So these are my takeaway points.
Thank you, sir.
Yeah.
Dr. Sanjay, are you there?
Yeah. Pankaj, thanks. What I feel is a very important point is most of the complications, especially when you begin your training or are during irrigation aspiration. You manage your nucleus and the precedent or whatever happens during irrigation aspiration. So one reason what I thought, because I have some juniors working with me, is that if you leave a big epinuclear plate, you have to spend a lot of time aspirating, trying to get it out. So what I feel is if you just do a good hydro dissection and do not do a hydro delineation, the whole nucleus comes out as a unit along with the epinucleus and much of the cortex, and you are left behind with less cortex. So you are in much comfortable in removing the cortex that way. And I also prefer a bimanual because it gives you more maneuverability. See, if you can rotate the eyeball whichever way, especially using both the hands, then you can go 360 degrees better rather than with a single instrument. So bimanual helps you in rotating the eyeball in whichever direction you want, and you can get the cortex out at 12 o'clock, 6 o'clock, whichever. So hydrodissection, no hydrodelineation, so that you're not left with a epinuclear plate. That makes much easier for your cortical removal.
Yes, sir. Really nice. I invite Dr. Pahuja, sir. Please share your insights.
Yeah. Two things. Am I audible?
Yeah, you're audible.
Okay, so two things what Dr. Sanjay said, that you have to do an hydro dissection, but probably I'll have a little more caution when I see sort of a thick PPC or thick PAC where I'm not sure about the poster capsule. There I'll definitely do an hydro delineation, and then slowly I just go over that. So that's only one point of caution that I would say for this. And the second thing is whether, what Dr. Anil Shah showed is the side port, side aspiration port is, I think it works very well because you have an irrigation which is going on, and then you're just holding something from the side. But because I convert a lot of my facos into small incisions when you are in a trouble. In that, probably I think the control that you have within a bimanual irrigation aspiration is better than, because I don't use Simcoe. So for me, machine is already on, so you just continue with that. I think that one thing was that when you remove a nucleus, and after removing a nucleus, usually the pupil constricts. I would suggest at that time, probably you can use a phenocan and then dilate in the pupil. Just wait for maybe half a minute, and you see the pupil dilates, and then you can do that, because this constricts only because of a trauma. And once you put a phenocan, probably that will just give you a better idea of that what you're doing it, because the surgery becomes very confident what you see and remove it. So that was one point that I say that you do that. The third thing was that when you have a capsular rhexis run out, at that time I would say that the cortex that you have to remove it should be the last where there is a run out. You remove whole of a cortex from everywhere, and at the end you just remove that, because that gives you a support. It works as a support where your capsule is not going to run out further from there. So that was one point that I want to say. Otherwise, the presentation, the videos was superb. That encourages you that you still can do an SICS. Thank you.
Thank you, sir. Thank you. Dr. Ame, I hand over to you.
Anand Pangarkar, sir. You call Dr. Anand Pangarkar, sir.
Dr. Pangarkar, sir. Yeah.
Hello, am I audible?
Yeah.
Very crisp presentations, short, to the point, excellent videos, and great teaching. I thought I will add a few things. Between a Simcoe and which uses the irrigation aspiration ports in very close proximity, which is the cause for the cortex running away from you when you try to aspirate. That whole thing is solved by the use of AC maintainer. However, there is one objection to the use of AC maintainer from an inferior port, and that is it is an exposed port and likely to have more chances of infection. But otherwise, AC maintainer is an excellent thing, and very little maneuvering is necessary even to remove the epinucleus. I compliment Anil Shah and the Arvind I people for that spring-loaded syringe to help us in manual aspiration. All that we have to take care is that the aspiration has to be a little less than the infusion if you don't want to catch the posterior capsule. Because the most important step where ECR, which is a dreadful complication which occurs, is during the eye. So generally we are a little relaxed, the nucleus has been managed, and
Yes,
we are just a step. Yes. We are just a step away from a successful surgery. That is when we are sometimes overzealous and inadvertently we catch either the posterior capsule resulting in a zonular dialysis.
Yeah, by 5 minutes only.
So with that, I must compliment everyone and thank you very much.
Daswala, sir.
Daswala, sir,
Very
please.
good. Yeah. A very good evening to all of you. A fantastic presentation. All the presentations were excellent. As usual, apna Anil bhai has come up with new concepts, and I think they are very useful for the beginners especially. I feel it has to be done. And what Dr. Paranjpe also showed about the UV light, I think very few. Is this commercially available, Dr. Shekhar Paranjpe, sir?
Yeah, yes, commercially available from Sharp Edge people.
Okay.
Yes.
Yeah.
And is there any study that using that you have less of PCOs and all? Then it is worth having it at all
It is
levels.
definitely a good.
No. Now you see, there must be very personalized studies because not more than 10 surgeons must be using it. So my personal experience is definitely in favor of that.
Yes.
And,
But after using that, you have less of PCOs?
yes.
Anil,
Less than 1%, I would dare to say. Otherwise, 5
you need to just have 50 cases in which UV light was used and 50 non-UV and find out the PCO rate.
Absolutely. That will give a good idea exactly how good it is working.
Yeah.
So anyway, all the presentations were excellent. We really enjoyed it. And I'm sure there are a lot of tips to be taken by the newcomers and the postgraduates in this SICS. Thank you very much, Dr. Anil Shah and Dr. Marathe, for making me the chairman of this session. And a big thank you. Thanks
Thank
a
you,
lot.
sir. Dr. Saurabh
Just one
Luthra wants
small-
to contribute.
Yeah, I just wanted to ask, sir, with this UV light thing, is there any untoward effect also? I mean,
Absolutely no. Absolutely.
Okay.
Just think about
And
that.
Dr. Paranjpe, what is the wavelength of this UV light? Because
It is-
there are different wavelengths, especially you're using this intraocular. Like
UV,
for P3R, you have 365 nanometer.
UVA, somewhere between 375 angstrom unit.
Okay.
UVA.
That is safe inside the eye.
That too is very low intensity, and it works.
This is approved, sir. I mean, to be used intraocularly, is it?
Approved by whom?
I mean, is it approved by the by the FDA or something? You know, that
No,
is
sir, it's not something that approved, but it's a personal experiences that just work.
Personal experience.
Yeah.
We'll ask SICS to approve it.
No, what suggestion Dr. Saurabh is giving, probably you can have patent, you can have under your name.
Yeah, maybe.
It can be published and it can be
Exactly.
popularized.
I mean, if only 10 people in the world are using this, I think a population like us,
Not 10 people. Not many
any
people are
idea
using,
about
sir.
it.
No, it's not 10 people. Not many people are using it.
Okay. Sir, I mean that was an eye opener for me. I haven't seen that, but it's good. Always
It
something
is
to learn.
good and non-invasive.
Yeah.
It is non-invasive.
It
I
comes
mean,
in a disposable this thing. One is 20 gauge fiber optic cable. Other is 23 gauge fiber optic cable. I use
Fairly goes with our FECO side port also then.
yes,
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 it has to go through on a FICO side port only.
yes,
Absolutely.
yes.
Anyways, thank you. Thanks again for having all of us.
It just loosen out the cortex from equator and post capsule, and then just flushing with the saline also they come out. So it's a wonderful thing.
There's another little curiosity that I've noticed. Nowadays, we all like to do CCC, and possibly I do about maybe 95% CCCs. But there was a time 20, 30 years ago when we did extra caps and we did SICSs, and all of them were can openers. And we did a wide anterior capsulotomy. And what I have noticed is that all those patients, even 20, 25 years later, when they come back, the rate of PCO is very low, very, very low, much lower than it is with your FACOs and with your SICSs with capsular excisions.
Absolutely true.
So although everybody doesn't like to talk good about can opener, but I think as far as PCO is concerned, can openers definitely give you way less PCO than with Rexes, possibly because you remove a lot of the anterior capsule that contains the cells that will contribute to the fiber growth. But the fact that lots and lots of those patients are coming 20, 30 years later with no PCO whatsoever, it's quite amazing even to me.
So would you say, Dr. Bhatti, that you do first CCC, do FACO, implant the lens, and then open the capsule?
Well, that would be pointless. That would be pointless because the whole elegance of the procedure, or if you want to actually even centration, I'm a little doubtful. If you use a 13 lens, the centration with a CCC with a can opener is very good. But some of these things we can't go back, even though we know that there are advantages to the old technique.
Also, Bhatti sir, I think the PMMA also had to do something with that.
Maybe because PMMA.
All those guys are all into that PMMA lenses. Those lenses were a class apart, I would say.
I think I would agree with you on that. PMMA lenses are way more inert than any of the lenses we have. And in fact, there was another lens that died unnatural death, but which was very inert, and that was a glass IOL. I had implanted a few of those glass IOLs. Dr. Bidai or someone from Baroda used to, he had got them from some American guy, and I had also got quite a few, and I implanted maybe 20, 30 of them. And they were extremely inert. Extremely. Absolutely, you would never find any lens placement.
But the main problem with is that you cannot do YAG there.
Yeah, you can't do YAG. I mean, it's risky doing YAG because
just cracks like anything.
Yeah, it would crack.
Correct.
You would be
in the best of your cases also, I am the second generation ophthalmologist. I would listen to my patients who would say that, your father did 20 years back, it's still doing good. With your surgery 2 years later, you're again wanting some charges to do YAG.
No, that does sometimes happen, that somebody, you operate him and 2 years later he has PC.
Sir, I would agree with Dr. Saurav, sir. I'm a third generation ophthalmologist. My dad operated 30 years, 40 years back. Those patients are doing very good, although they have got certain amount of astigmatism, but there's hardly any PCO, or they've got those PMMA lenses from Pharmacia. Now my dad used to implant 25 years back. And there is no PCO. I have not seen, and I have operated those cases 2 years back with good hydrophobic Indian. They have PCO. So
I have an Instagram page, and on that I think I'd put up a picture of one of those spider IOLs that I'd photographed, spider glass lenses. Just let me see while you all talk if I can quickly find it.
One of the main advantage of CCC and in the bag implantation is a very much refraction stability.
That's true.
It doesn't move forward. If
all these premium IOL and all the calculations will only work with these CCCs and an effective ELPs planned. That is only possible with these newer technologies.
And no change in effective lens position years after.
True.
one of the reasons why I feel with CCC in the olden days, PCO was less, because much of the anterior capsule was removed. Much of the anterior capsule was removed, and you had almost an open bag for you to aspirate the cortex. But with a CCC, you have little less access and you have to go behind. So maybe that is one of the reasons why PCO is less.
Yeah, that could well be so. And in fact, the other part is that when you do a can opener, you don't have to do any hydrodissection or anything. The nucleus just is in the AC anyway, because there is no bag to hold it back.
Yes, definitely.
This is not to say that we must go back to those days, but it is to say that if you do not get a CCC sometimes, it's not the end of the world. The eye will do pretty well. Yeah, okay.
It is known as romanticizing the past.
Not really. You have to appreciate the good things about the older.
Yeah, doesn't matter at all. I'm giving a compliment that there were some good things also, not all bad things.
One suggestion I would like to give, that whenever there is Rex's run out, I just convert it into a can opener capsulotomy. Multiple cuts I take, because otherwise what happens, that one Rex's run out, it takes all the brunt of stretching up of the capsule, and it extends posteriorly, and you may get even nucleus drop. And secondly,
that is correct. In fact, that is another way of saying that you make a can opener.
Yeah.
Okay, I'm just sharing the screen. Can you see this lens on the screen?
Yes, sir.
Yeah, this was called the spider lens. It had a brown carrier, which was of a material called polyimide, and the center is glass. And you notice how, of course, this is digitized from a slide, because in those days we didn't have digital cameras, so I shot it on a 35 mm through the slit lamp. And so it's a bit grainy if you notice the picture. But you'll see that the lens doesn't show any imperfections of any type. No lens states nothing. An extremely quiet eye. And of course, you can also see that this is a can opener.
Good.
bye-bye then. Good night, everybody.
Yeah.
Good night. Good night. It's been a pleasure.
Hello. Last remark from my side.
Yeah, Dr.
Thank you.
Please.
Dr. Prakash Marathe, sir, any comments, sir, please?
Yes. I think it was a wonderful webinar. All the presenters, Dr. Prashant Shukla, Dr. Saurabh Luthra, and SS Bhatti, sir, they presented very nice videos, and it was very nice interactive webinar. So all of us were almost busy for last 1.5 hours. That reminds me about the innovation of most of our colleagues, starting from Anil Shah to Dr. Paranspe, sir. I think what Dr. Paranspe was talking about and we were discussing, most of us are innovators. There are so many instruments. That reminds me Dr. Anil Shah's snare. He designed it. We were using it. We were discussing it, but it was not patented. And someone else outside India designed it and he got the patent. So that's what happens with our surgeons. So it shouldn't happen. We should be alert. There should be scientific study. It should be documented properly and try to do a patent for that particular thing. I think the new generation can take over all those things. And with this, I think it was a wonderful webinar. I am thankful to each and everyone. I hope that all the participants, like chairpersons, presenters, then discussants, and all the delegates must have been benefited. Thank you, everyone. Good night.
Thank you so much.
Thank you.
Thank you, sir. I call upon Pankaj Shah, sir, to please deliver a vote of thanks.
Thank you, Amin. I thank all the esteemed faculty members for the excellent videos and presentations, as well as the discussions for all wonderful discussions and points and takeaway messages, and the chairpersons, and of course, all the attendees who are attending this webinar, and Intode for giving us the support to host this webinar. Thank you, ISM-ICS Maharashtra chapter also, and President Dr. Anil Shah, sir, for such wonderful topic. Thank you, all of you.
Thank you very much.
Thank you, everyone.
Thank you, sir. Sir, I would like to say a special thanks to Dr. Anil Shah, sir, to have given me the opportunity to part of this wonderful session.
It is our pleasure. You have done a very good presentation, sir.
Thank you, sir. Thank you so much.
Thanks again, everyone. Thanks, Amay. Thanks, Pankaj sir.
Thank you.
Thank you, everyone.
Thank you and good night.
Thank you all. Thank you, Dr. Shah. Thank you.
Good night.
Good night, sir.
Good night.
Thank you, sir. Good night.
Good night.